Live now.
Good morning, everyone. Welcome to the deformity correction module. Today we have Sir, am I audible? Hello, sir.
Yes,
Yes, you are audible.
yes.
Today we have Dr. Mangal Parihar, sir, who will be talking on pelvic support osteotomies and the planning of Elizarov hip reconstruction. I'll just introduce sir in a brief presentation before sir talks. Mangal Parihar, sir, he does not require any introduction. He's a world-renowned limb reconstruction surgeon. Sir is consultant orthopedic surgeon at Center for Limb Lengthening and Reconstruction, Mangal Anand Hospital, Mumbai. Sir has done his MBBS from State GS Medical College and MS Orthopedics from KEM Hospital, Mumbai. He has various fellowships and has done his total joint arthroplasty under Dr. C.S. Ranawat, sir. And he's trained under Dr. Rod Paley, sir, for Elizarov and limb reconstruction techniques. Sir has also been trained for hip resurfacing surgeries. He's known for his advanced surgical methods, which he uses for lengthening and deformity correction. He deals with adult as well as pediatric orthopedic reconstructive procedures. Sir is well known for his fixator-assisted HTO and is a pioneer in bringing the hexapods to the country and in development of depth fix. He's the honorary assistant professor at Sir J.J. Group of Hospitals and Brand Medical College, and as well as Fortis Hospitals, Mumbai. Sir has been faculty at various international and national conferences and has trained various fellows all across the country and the world. He has conducted various workshops and has done various demonstration surgeries in various cities in India. Thank you, sir, for accepting our invitation. So, you can share your screen, sir.
Okay. One second.
Yes, sir.
Okay, you're able to see the screen?
Yes, sir.
All righty. Okay, so I'm going to talk mainly, I think the theory part about hip reconstruction, many of us know. I think one of the issues about analysis of hip reconstruction is how to do it, right? And in many of these situations where you have a very unstable hip, there are various procedures prescribed. I think this is a procedure which will almost always work when you have neonatal septic arthritis, whether Tom Smith, where the head is completely damaged. Untreated DDH probably is getting to be hopefully a relatively limited indication, because our pediatric colleagues are able to catch DDH, but in unilateral one side, there may be a case for doing an Elizarov. Older patients where a girdle stone has been done, or there is a non-union after a fracture neck of femur. But in younger patients, this is more important, I think, because doing a hip replacement in a younger patient is not a good idea. The issue here is the unstable hip as well as the limb length discrepancy. Now, you can't just lengthen this, because if you just lengthen it, there's no reason why the knee is going to come down. It's the trochanter can go up as well. So for that, we need to, fashion something which will give stability at the hip also and allow us to lengthen. So pelvic support is not something that is new. It has been described earlier. There are various levels and there are various names ascribed to it. But essentially, all of these procedures which are done are for the frontal plane only. That is, they give abduction. They don't usually correct flexion, extension, and that, as I will talk about later, is probably an important component of the hip reconstruction. Also, they do not correct the limb length inequality. And the excessive valgus that is required, you see patients by the age of 35, 40, if they have had a, really valgus abduction osteotomy, they will get lateral arthritis in the knee because the mechanical axis is deviated laterally, as you can see in this patient. So unless there is a compensatory varus osteotomy distally. So this is essentially a 2-in-1 procedure. It is a regular PSO with a little bit of modifications proximally. And distally, there is an osteotomy which will allow you to do the lengthening as well as the realignment. So the proximal osteotomy essentially is extreme valgus. And the way that this gives you stability is basically you're putting the limb into maximum adduction. That means you take away all the adduction, and therefore the pelvis cannot drop. The trochanter is shifted laterally and distally, which tensions up the abductors. But I think more when there is no fulcrum at all, this part is a little less important than the fact that it takes away all the available adduction. So if there's no adduction left, the pelvis just cannot drop. There is also in this, we can add extension in that. So it eliminates the flexion deformity because the hip usually has gone behind. And when the patient is standing, it uses the anterior capsule to stabilize the hip. The third thing which we do in the proximal osteotomy is internal rotation. So this compensates for the external rotation. Whenever you adduct the limb over the other one, there is an element of external rotation that comes in. So we add internal rotation to compensate for that. The distal osteotomy is usually mid-diaphyseal, and the planning of this is kind of critical because it can lead to otherwise mechanical axis deviation. And when we used to do it with the Ilizarov, we would do a lengthening initially and then do a realignment. Now, when we do it with the rail fixator, we do the realignment first and then the lengthening. So here, when you want to plan this, clinically, we are looking at what's the adduction-abduction arc. Is there some adduction contracture? What's the flexion extension and a flexion deformity and foot progression angle? All of this is basically because with this, you come to know, how much rotation, etc., because that cannot be checked on X-ray. Adduction, abduction, we factor in from the X-rays, how much adduction, abduction we want. So we do a maximum adduction view. And with this, we can plan the level of the osteotomy and we can plan the amount of valgus. So usually we do this at the ischial level, so that entire length of femur, which is above the red line, osteotomy line that you see there, is available to kind of, be supported by the side of the pelvis. I don't think anyone knows for sure where this adducts, but where this contacts the pelvis, but there is a wide area in which this can be in contact. And for the angle, we the amount of valgus that is needed. So this green line that you see here is the pelvic line, okay, from the inferior portion of the SI joint, a transverse line. So this gives you the line of the pelvis. From there, you drop a vertical line, 90 degrees, the line marked as C over there. And then that maximally adducted view is the angle that is needed to bring, after you do the osteotomy, to bring the distal portion in line, or rather perpendicular to the line of the pelvis. So in this case, to get the leg straight while keeping that proximal femur in maximum adduction, you would need to do 36 degrees of correction. On top of that, we add about 15 degrees for over correction to maximally tense the abductors. So normally around 50-55 is the angle that you tend to get when you want to do this correction. So here you can see this is 36 plus 15. Then you do the maximum abduction view, looking for any adduction contractures. This will be important when we do the distal osteotomy. And if there is, then you would need to release the adductors prior to going in for the surgery. Then, of course, the full-length X-ray to find out how much limb-length discrepancy is there and the various angles. The same thing or something similar is achieved by a single leg stance. A single leg stance X-ray where the patient is, you do this with the patient facing the X-ray tube, not the X-ray plate, not the X-ray tube like you would do normally. And the other leg is flexed. So patient will need a little bit of support on the sides, some bar or somebody's hand so that they're able to balance. And this ensures that what you are measuring as the adduction angle is correct. So again, here you check the horizontal pelvic line, you draw the perpendicular to that, and you draw the femur anatomic axis. This is similar to what we did in the maximum adduction view, because ultimately your goal is that the pelvis should not drop when the patient is walking. So you have that adduction angle and you add 15. So I usually do both of them to confirm that, yes, I'm not making any mistake in either of them. Sometimes the pelvis may not drop enough. Sometimes the adduction may not be enough. So I will do both and cross-check to confirm that, yes, they are similar. So same thing showed over here. Now, this giving this angle is amenable to lengthening, because now if you lengthen this femur, the proximal portion is going to push against the pelvis. And therefore, there is unlikely to be any proximal migration of the trochanter. So this was the original theory. But now, even when we are correcting it with the LRS before surgery, before lengthening, I find that there is no real upriding of the trochanter, right? So here, and ultimately now once the pelvis is level, then we draw this perpendicular which passes through what used to be the acetabulum. Okay. And that vertical line is taken as the proximal axis, and the axis of the tibia continued into the femur is taken as the distal axis. Now, if you have significant abnormalities in the distal femur, like a valgus, which I have not seen, but you will have to factor that in. This approach presupposes that otherwise the distal femur and the proximal tibia are relatively normal. If, let's say, the tibia is abnormal, then you will just extend the distal femoral axis to intersect this. Where these two intersect is the appropriate area for doing the distal osteotomy, because when you correct it at that cora, your red line and your blue line will be collinear, and therefore your mechanical axis will now be straight, and you will not overload any of that, right? So here you can see that if you don't do this, the mechanical axis would pass from this line over there from this point of the acetabulum to the distal tibia, and that would be a valgus force that would go somewhere over here. It would not go through the center, and that's the reason why when you do only a pelvic support without the varus osteotomy distally, you get overload on the lateral side and lateral arthritis that way. And once you do it like this with the curve at the osteotomy, then you get the both of them aligned, right? So there's a question on the chat how to draw the proximal axis. The answer to that is you draw the pelvic line, a perpendicular to that. Let me go one before. Pelvic line perpendicular to that, which passes through what used to be the acetabulum. That's the proximal axis. So, and ultimately then this is what it looks like when you've completed the procedure in terms of lengthening, etc.
Sir, can I interrupt and ask you a question?
Yeah.
Now, in younger children, we see the amount of valgus we give, fair amount of that gets remodeled. So do we
Yes.
factor it in doing distal varicization, or how to do that?
No, because
You understand?
yes, I understand. But if your proximal severe valgus is going to remodel, which it does in children, then the varus which you do distally is much less than that valgus. That will also remodel. So when I'm doing it, I would, first of all, I would not do it in a child who's like 7 years and 8 years old, because the potential for remodeling in that is very high. This child, number one. Number two, if there is significant shortening, like currently I'm treating a child who's, I think, about 7 years old or something, who's got a congenital, and for that we are doing a valgus and a lengthening, because she's pretty short. She's almost about 6 centimeters short. So if I wait till she's older, I'm going to have trouble. There, what we've done is we've discussed with the parents that this is all going to remodel, and later on she may require a similar procedure again, which is that is better than waiting for such a child to develop a limb-length discrepancy of 13 centimeters and 14 centimeters and then try to correct that in one go. That becomes much more difficult for the patient and for us as the surgeon.
So
So-
while we are correcting it, we have to make sure that mechanical access is
to the
centralized.
center, yes. And then
And-
in the future, if it changes, whenever you do the correct, because you can't predict how much, which of these
Mhm.
osteotomies is going to remodel.
Okay.
So it can just be done again. If you are, for
Yeah.
example, if your valgus does not remodel too much, then you may just need to do a lengthening osteotomy. If the valgus remodels too much, then again that same concept will happen, that the trochanter can go up. So therefore you need the pelvic support. So that 11, 12, 13 onwards is what I would do it. And in them, repeat osteotomies, we will counsel the patients, about doing that. Now you can do it with an Ilizarov, which is how we used to do it earlier. Occasionally, I will still do it when it's a really difficult case to plan, because it allows me any amount of adjustment, especially if I use tech support. But it's more inconvenient for the patient. And once you've done a few with the Ilizarov, then you get the hang of where the osteotomies should be and what the angles should be, and then I think it's not too difficult to plan it with the monolateral. But the monolateral, if you don't plan it properly, then you can land up with trouble. And I'll show you both. I'll first show you how we do it now with the monolateral, and then I'll show you Ilizarov case. So this guy had an awkward gait, absent head and neck, and he needed length. So we decided to do that. All of them have this hyperlordosis with a little bit of flexion. Surprisingly, many of them, their gait will not be terribly bad. For some reason, I think it's the fibrosis that lands up following the infection, etc. So the gait-wise, they are not so bad, but definitely their pelvis drops. They have to lean over onto the other side. So in such a case, I think the main reason for doing the Ilizarov hip reconstruction is less for hip stability, but more to ensure that you are able to lengthen, right? So effectively, this is how we are going to plan that. The proximal extreme valgus, as I said, with the maximum adduction angle, and distally over here usually tends to be around the midshaft. We do the osteotomy and lengthening, and with that you can see that the axis is straight. So that's his adduction angle of 44 degrees. So here the single leg stance shows a lesser amount, right? So that would give us an angle of only 26. And this is not matching with that earlier view which I showed you. So he had problems with balancing. So therefore, this I would not take as the number. In this situation, I would take that maximum adduction. And that's the reason I said I like to do both. Now, how do you
So sir, you decide the angle which is more.
Yes, yes, because 11 degrees is not the cannot be the, So usually to get that amount of abduction, the if it is anything less than, I would say 40, 45, my antenna would be up. What is happening over here? Why is this so little? Because that the operative word there is extreme valgus.
So I think this extreme valgus will get only on adduction films,
No, you get it. We get it on
standing films also.
Yes, if they are able to balance, then you get it. And more often than not, we will get equivalent, meaning there may be 5 degrees, 7 degrees of difference, but
So-
not such a marked difference.
So how the standing film changes your decision? That's what I wanted to ask.
No, I'm just doing it to confirm that both are equivalent, because ultimately my goal is to get the pelvis level when the patient is standing on one.
Standing, okay.
So that, since that is my goal, I like to factor that in as also a point that I will see. And it's like, when I do anatomic axis planning as well as mechanical axis planning, you can well do it with only one planning. But I will use both of them to cross-check against the other. Am I getting the same number? Am I getting the same level? So generally, that's a habit that I have developed over time. They say a good carpenter measures twice, cuts once. So for anything that I'm going to do that has a significant effect on the patient in the long term, I will always like to be doubly sure. And it doesn't take me too much time to get that done. Then how do you translate this into the theater? So first of all, I keep a long elixir of wire on the pelvis to see what is the pelvic line, that same inferior sacroiliac joint. And I will mark this with a marker pen. So visually, I can see that pelvic line, because the pins that I'm going to put are going to be parallel to this line, right? So now you can see the mark over here, and I've got a ruler placed over there. And from here, I will go into maximum adduction. In this adducted view, I will put my pin parallel to that pelvic line while maintaining the hip in maximum adduction. So here you see a drill bit going into the tip of that trochanter to prepare for that first pin. So now this is this pin. Therefore, if you think about the future, once the leg is straight, this pin is going to be parallel to the pelvis and going to be parallel to the ground.
Huh?
When you look at it from the side or end on, this drill bit or pin is parallel to the ground while the leg is in maximum adduction. Now the second set of pins, and once you have one pin in, you can put in with the template, you can put in the second pin also for the proximal fragment, that is this one. Once you've got this, you fit a clamp onto this and then pass in the second pin. Now at an appropriate distance, which means usually about 2 finger breadths, you put in the second pin at the required valgus angle, which we had calculated. So 50, 55, whatever it may be. Now, how do you get this valgus angle? There are a couple of ways that you can do it. One is, I have a protractor which is printed out on OHP. And so I will put that protractor along this line. Let me change the color.
What is OHP, sir?
Overhead projector, the transparency.
Okay. Okay.
So I will put that. So that has got all degrees on it. So it is done at a zoomed in view. Okay. So now I can measure the angle of this pin. which may be, let us say, 30 degrees to this point. And then I will make this angle also using that OHP, meaning I put a K wire, measure that angle, and then I know that, okay, my angle is appropriate. Or what you can do on, if you know that 40 degrees is what I want, you can create a paper or a aluminium cutout of that appropriate angle, place it below this pin, and then put the second pin, right? Or third thing is, you can use those angle guides which you get in the AO osteotomy sets and all that, which have got different angles, multiple ways of doing this. So when I put this pin, I will confirm on the C-arm using those methods that this is at the appropriate angle. And then using this pin itself as a template, I will put in the second. So now I've got two pins which are parallel, not parallel, which are at the appropriate angle, two sets of pins which are at the appropriate angle to each other that I want to correct. In addition, when I put that distal pin, I will put it, like you see this wire over here, I will put it slightly posterior, that is externally rotated to the proximal pin. Why? Because when I adducted it, I created external rotation. So I want to add internal rotation. So if you can think of this in 3D, when you look at it from the top, there is an angle of 45 degrees to each other. When you look at the pins from the end, there is a rotation angle of about 10 to 15 degrees between those two sets of pins. So when these two sets of pins come onto one rail, I will have created internal rotation. Also, I will adjust the pins slightly to create extension in the osteotomy. So there will be a apex anterior angulation, so that apex posterior angulation, so that when I correct this, the osteotomy will be slightly extended. There is a limit to how much you can do this, because the way that you can adjust this is that's the bone. And if you put the pins in a slight angle to each other, this is looking at it dead lateral. The moment this clamp comes onto the rail, it will create a flexion or extension depending on which direction you're doing it. Is that clear?
Yes, sir.
Yeah.
So you can add a little bit of extension. Now, this is one of, if you want to say, the drawbacks of the LRS, because LRS is in one plane only. So the amount of extension that you can add is limited. Whereas with the Ilizarov, you can add a lot of extension. So if there is a significant flexion deformity, then I would tend to use an Ilizarov, because with the Ilizarov, I'm not constricted or constrained to one plane. I can correct that any amount of flexion extension. This is more for hips that don't have a fixed flexion deformity. And that's where, again, what I was talking about, the clinical examination, that becomes important. Those are things which cannot be estimated on X-ray, right?
Now, sir, can we put the pins in the distal fragment more
Not as
anteriorly inclined to correct the rotation? I mean, to give internal rotation, can we put the pins in the distal fragment?
You can, but what's the advantage of that? There's no advantage of putting it in the distal fragment.
Why I'm asking is because the proximal fragment is smaller.
Yeah.
While the
even the distal fragment, I'll show you. I want to be as proximal as possible, because then you have less you have less tethering of the soft tissues. So whenever I want to do the osteotomy, I will tend to do it more proximal. Of course, it is distal, but in that also, rather than being near the condyle, I will, if I can, be closer to the diaphysis.
So to give internal rotation, you want to put the pins in proximal fragment in about few angles. What I was asking is, can we put the pins in the distal fragment from bit posterior to anterior? So when we align it on a rail, there will be internal rotation of the extremity.
Yes, you can.
That can be done, right?
Yeah. So then we do the osteotomy at the ischial tuberosity between those two sets of pins, and then get those pins parallel to each other. So now we've got those pins parallel to each other, and they are on a rail, and you can see that immediately the leg is, this is somebody supporting the leg over here because the leg is in valgus, right? We are not holding it in valgus. This person is just supporting that because otherwise the leg will fall. And now we've got the pins distally again at a particular angle to this set of pins, which was the varus angle that we have decided in the planning. So that when this osteotomy is done and these pins also come onto the rail, the varus will automatically be corrected. So that's the proximal, not the proximal, that's the second set of pins. Most proximal is up here. This is the proximal osteotomy. Now, in relation to this set of pins is being put at a angle so that when these two pins become parallel, that amount of varus, which was, let us say, 15 degrees, which we had calculated there, that amount of varus will come in. Again, once you put in one pin, then you can use that pin itself as the template. And the important thing is that these two pins now, in my situation, because I've already corrected the rotation here, they should be in the same plane. Whereas if what you are saying is these pins you will put from the posterior and then correct that rotation over there, right? But if you're doing it the way I'm saying, whichever way you do it, you have to ensure that the rotation is maintained or kept sight of when you're putting the pins in. It's not only the angulation between the two, but end on always that rotation, they should be in the appropriate plane. And the moment you do your osteotomy and get these pins onto the rail, you now have a certain amount of varus which is coming. This varus is always less. It's not that we put 55 degrees on top, therefore you will have 55 degrees of varus over here. No, with 55 degrees of varus, valgus, usually the amount of varus that is required is about 10, 15, 20 degrees. Usually somewhere around 15 is what it normally comes to, right? But that depends on the particular planning. So now you've got your osteotomy completed and you are set up for doing the lengthening. And we check the mechanical axis, that's at the hip, that's at the ankle, and that should be in the center of the knee on the C-arm. So that's the post-op x-rays. This, since it's closed, if at all you have to displace this, you should do a lateral displacement based on Cora principles. That is, whenever you have abduction and the Cora is in the proximal region, you will have lateral translation of the distal fragment. So that's what this is. And position after around 10 days. Normally we start distraction in 7 days. Here we've done an acute correction of the angulation. Therefore, I will give it a little more time for it to settle down before I start distracting. The other thing is, look at where I've done this osteotomy. I've done it as proximal as I can because I want to have less tethering of the soft tissues on the distal portion. And that's doing a full length X-ray to measure his length. Axis is straight, but he needs 20 millimeters more. Initially, oftentimes, because of the tight abductors, the extreme adduction and the abductors becoming tight, patients may have a little bit of an abduction deformity, and that's a good thing because over time that will stretch out. So having an abduction deformity in the early period is a good thing. So that's him at 6 months. Now his proximal osteotomy has healed well. Regenerate is not healing as well, which can be a problem in either situation with an LRS or because these are bones which are not fully normal. Number two, sometimes they are extensive lengthenings. So for this boy, he was developing trouble with lysis, with the pins and all that. So we took off the pins and put in an internal splint, which is easy for the patient to do. Just a long locking plate to be used as an internal fixator. Now, this plate doesn't have to be fully apposed to the bone because this is a locking plate. So you've got just 3 pins in the proximal fragment, 3 pins in the distal fragment, a little bit of contouring so that it's not standing too far away, but it doesn't have to be absolutely laid to the bone. That is done through those incisions, and it's done in one go, meaning you take off the fixator, curate out the pins, take a culture, and slide the plate in. That's 11 months, by which time he's healed, but more importantly, he's got this protection inside. So totally that abductor lurch doesn't go away in this situation, but it is definitely improved. That is, his length has been restored. And more importantly, if you see the right side X-ray, there is no drop in the pelvis when he is standing on this side. There has been some loss in the valgus. But as I said, the valgus is for two reasons. One is stabilizing the hip, which if you notice his pre-op walk, not terribly unstable. And the second reason is to allow us to lengthen this large amount without the trochanter slipping up. We've just seen him recently. He's continues, there's no further remodeling on that. But if there is, then yes, you can think about doing that. So the advantage for the hip reconstruction is that there's no blood loss. You can get your length. The axis is normalized so that future they will not have knee arthritis. And these are some other patients. Where is that working? No. I don't know, this video is not working, but I was... So there is a good amount of literature on this Elizarov hip reconstructions, which says basically that the long-term results are pretty good. They don't develop pain. They remain active. Range of motion in the hip remains. Now, one of the problems with the Ilizarov hip reconstruction, especially if you do it with the LRS, is the importance of the level of the osteotomy and in the importance of the planning. So here is a case where we made a mistake in terms of, and this is the reason why the osteotomy has to be as high as is needed. So we did the osteotomy more distal, and because of that, there is a lateral translation of that distal fragment, right? The other issues with fixators, pin side infection, delayed consolidation are there, and they can be taken care of, as I showed you. Knee stiffness can be avoided by having the pins high up. You saw how much range he had just a few days after. This was at 10 months. So this is about 1 month post-op of the plate. This is 11 months post-op of the lengthening, but 1 month post-op of the plate. And that's a pretty good range of motion. Now his range of motion is complete. Now, the one objection to hip reconstruction today is that future THR will be a problem when you create this. Yes, that is something that you have to think about when you're doing it in adults. But I think for a person who's 20 years old and 25 years old, especially from a rural background, who needs good hip movement, this is much, much better than a THR. And for children, younger, the 13-year-olds and the 15-year-olds, certainly. Technically, even if you need to do a THR in the future, it can be done. You just have to undo the osteotomy, and this has been reported also. Out of 24 patients, 4 of them required a THR, and they could do it after doing a proximal tibial osteotomy. I'll just show you a couple of other slides when we do it. The funda is the same when we do it with the Ilizarov. Pelvic line, pin parallel to the pelvic line, and here we are using an arch. So there we keep the arch perpendicular. So because these pins are then in different direction, then you uncross the legs and put in the second pin, same as that. Only thing is, here we are using an arch, and the moment you bring those arches parallel to each other, your valgus angle is corrected. But in addition, you can play with the arches, looking at them from the lateral in terms of flexion or extension to get that. Okay. And you stabilize those arches with connecting rods, and then the distal wire is parallel to the joint line. So this is what it looks like. So now here we've got a hinge, and this is still not angulated. So we distract in this direction, and once it is length is achieved, then we do the deformity correction, that is through this hinge. So that's what it looks like when you do a Ilizarov. Now these are the 2 arches which are looking. So you can see clearly I can do any amount of extension. Here what I've done is I can do any amount of extension of the distal fragment as I want. So when there is a flexion deformity significant, then I will tend to use the Ilizarov. Otherwise, I will use the LRS. So that's it. Now I would happy to. How much time do we discuss?
So we have about 10 to 15 minutes more, sir.
Yeah.
And we have few questions, sir.
Yeah.
So from Dr. Bhushan Sagade, sir, do we displace the distal fragment of the proximal?
Laterally.
Yeah, laterally only.
Which distal fragment? That is the intermediate fragment. Distal fragment of the proximal osteotomy is displaced laterally. Distal fragment of the distal osteotomy does not need to be displaced because we are doing the osteotomy at the cora only. How much time apart you girdle? I have not, most of the patients that I have seen or done have been Tom Smith. I think 2 we have done girdle stone, which were at least about 2-3 years after the girdle stones. So I would give at least a year or so for soft tissues to stabilize, fibrosis to do its job, and only then go ahead with doing the valgus osteotomy. Future TKR, Shakti, I think I answered that question. Many of them will not need it, and theoretically, I mean, if it is needed, then you can redo that. The results of total hip in young patients, in terms of the long-term life, I think are not very encouraging, number one. Number two, the results of total hip in dislocated hips is and young patients is even worse. Right? How do you measure the leg lengths after IHR? Is by a full length X-ray. You saw that I showed you a picture where I said 20 millimeters remaining. So we get them standing, do a full length X-ray, and then do the further lengthening as required. Would using an LCP for proximal osteotomy help with the problem of remodeling? No. Remodeling occurs despite whatever you use to fix it. If you fix it, in fact, if you fix it with an LCP, you will not be able to get 50 degrees of correction. 50 degrees of correction is only possible, really speaking, with an external fixator. You try it. You bend the plate and try to do the osteotomy, that the apex of that plate will be deep inside, and you will be struggling. So, and plus, I don't think it helps for remodeling. There's one more. Gaurav Gupta asked, how often do you find a mismatch between the two? That means, I think he's asking about the adduction view and the standing view. All of them may have a difference of about 5-10 degrees. That I can ascribe to the fact that standing there's not full sort of adduction happening in the standing film. But if it is significant like this, then of course I will take. I usually will take the larger number, and it's not a problem to have a little extra abduction. 5-10 degrees of abduction, as I said, in the post-op period, will gradually stretch out over time. In case IHR is to be reversed, I have never faced that problem. And then, what are the bloody arthroplasty surgeons there for? Fokat mein paisa kamane ka. They have to learn how to do a reverse. It is doable. Meaning, whatever osteotomies you have done, see the problem in arthroplasty for these patients is less the osteotomy. You can do the osteotomy, put in a long Wagner stem, for example, and you will get the femur reconstructed without trouble. The issue is, where will you put the acetabulum? How tight will it be when you try to reduce that? Dr. Herzenberg's paper on technique for IHR says that the intermediate fragment, I'll have to check that, but I'm fairly certain that I am correct. I'm talking based on principles of deformity correction, that is cora and when the osteotomy rule number 2, if the cora is proximal and the osteotomy is distal, then it will translate laterally. I will check. You can send me Dr. Herzenberg's paper, and I will. When was that paper done? A lot of things change over time also. So let me just check and then I'll get back to you on that. Yes, Sudhanshu Vansal, adduction view, if technician flexes the leg over the leg, other leg to adduct, can give false picture of over adduction. You always have to flex it a little and externally rotate it to get the maximum adduction. But that is the amount of adduction that is required to ensure that the femur is abutting against the tibia. So if you can think of it in 3D space, in the pelvis, your acetabulum relative to the ischium is slightly higher. And the tip of the trochanter is slightly posterior. So actually, when you're doing an abduction, you do want a little bit of flexion of that proximal fragment. So that is appropriate. So I don't think it creates a false picture of over adduction calculation. It gives you the right amount of, and as I said again, you check both. You can't, even if you flex the leg and a very strong person pushes it, you can't go beyond the compressibility of the soft tissue on the anterior inferior portion of the pelvis. There's only so much adduction that you can do. So I think over adduction is really difficult. We want that much of adduction.
Yes, sir. So, no more questions, sir.
Right.
So,
We are at the appropriate time, only 3 minutes remaining. So,
Yeah, so that was a nice talk, and I have heard this for a few times and still enjoying it. And I'm sure all the youngsters should go through this talk when they are doing the next, and that will help them. Thank you, sir, for your time.
welcome. Bye-bye.
Bye-bye. Goda, you can conclude.
yes, sir. Thank you, sir. Thank you so much. And the next talk will be on tibial hemimelia by Dr. James Fernandez next week. Thank you.